Good afternoon to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Sanjay Chaudhary. Sir is MBBS, MD, Senior Consultant at Pediatric Department at Fortis Healthcare, Jaipur. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is management of neonatal sepsis and infection control. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, sir.
Uh, thank you, IJCP, for giving them this platform for discussing various clinical topics of public importance and discussing clinical overview with the fellow academicians. Yeah. So today we are going to discuss about neonatal sepsis, that is infection in newborn period. It is one of the key reason of poor outcome in newborn care, and has significant amount causes significant insult in mortality to the newborn, and have a long debilitating course if not treated well during time. So there are few definitions that has to be discussed before going deeper inside of neonatal sepsis. Common definition which we are using in our day-to-day practice is probable sepsis, clinical sepsis, culture proven or definitive sepsis, neonatal sepsis, or at risk, that is newborn at risk of having sepsis, or we are planning or ruling out sepsis, or we are suspecting sepsis. So these are the common terms which we use in our day-to-day discussion or clinical examination during daily routine ward rounds. So probable sepsis, we call it as if the child is clinically and laboratory findings are consistent with the bacterial infection without a positive culture report. So culture report is pending, or the culture report is turned out to be negative. We call it as the child is having clinical features of sepsis, and the laboratory findings, that is CBC, CRP, and other markers, they are consistent with bacterial infection. So we call it as probable sepsis. Second definition is clinical sepsis, when the screen and blood culture CSF culture is negative, but there is clinical history and examination is highly suspicious, suggestive of sepsis. Culture proven or definitive sepsis where the clinical features are there, and the culture, blood culture or urine culture, CSF culture, or tissues fluid culture, they are turning out to be positive, and the child has clinical features of sepsis. We call it as culture proven or definitive sepsis. Neonatal sepsis, when a newborn having clinical or systemic features of sepsis associated with pure growth of a bacteria, specific bacteria, from one or more than one side. The last one is at risk, where we are planning to rule out sepsis, where we are suspecting sepsis could be there but could not be there. So there are doubtful clinical findings, and we are planning to say the child is do not have sepsis, it is having some other etiology, but to be very sure that we are not dealing with sepsis or infection, we send investigation to rule out sepsis. So often we suspect sepsis basis on risk factor, clinical features, but the clinical course, there is a rapid recovery in few hours after a first clinical examination, or the screening tests are not very suggestive of infection or sepsis, then we label that child as suspected sepsis, and that is there. Our purpose is to of investigation is to rule out definitive sepsis. What could be the common mode of transmission? Vertical transmission, that is, the child may have acquired infection in utero, that is from through placenta or uterus, either hematogenous or amniotic fluid, or during the process of birth. The symptom usually manifest within first 72 hours of life. That is, within 3 days of birth, the child or newborn baby shows the symptoms of sepsis. Or there is horizontal transmission, that is, it could be hospital acquired. Majority of them are late onset sepsis, that is acquired or manifesting after 72 hours of life. Our breach in asepsis during resuscitation immediately after delivery is also called, can be termed as horizontal transmission. That can be acquired at home at the during delivery at various places, or during immediate neonatal care, where the variety of traditional practices are prevailing in our society, giving gudlia or some oral medication, or applying some material over umbilicus, such as cow dung, haldi. They many a times can cause infection, and that's infections spread to bloodstream and can give rise to sepsis. What could be the possible risk factors? Perinatally, we call them perinatal risk factors, and if they are of severe variety, extreme variety, uh, where there are high chances of infection, we call them as extreme risk factors. So if there is a rupture of membrane for more than 24 hours, then we call it as routine perinatal risk factor. If the rupture of membrane occurred 72 hours back, then it is of there is high chances of the child is having infection. The birth of the baby is spontaneous prematurely, then it is a risk factor. Chorioamnionitis, the placenta has showing features of infection. There is prolonged labor, unclean pervaginal PV examination, or frequent PV examination, or there are features of perinatal asphyxia. Then that situation is termed a perinatal risk factor. Extreme factors are rupture of membrane more than 72 hours, chorioamnionitis, foul smelling liquor. They are extreme risk factors. How to intraamniotic infection or inflammation, or both, where we find that the mother is also affected, the baby is also affected, and the investigation suggests that there are chances of infection. So maternal fever, if there is fever to the mother or to the tune of more than 39 degree on one or many occasion, if the oral temperature is 38 to 38.9 repeated after 30 minutes, if repeat value remain at 38 degree, it is defined as fever. Suspected triple fever without clear source of infection with uh, baseline fetal tachycardia, that is, the baby's heart rate is more than 160 beats per minute for persistently 10 minutes, then we call it as persistent fetal tachycardia. uh, Maternal leukocyte count, TLC of the mother blood, if taken, shows more than 15,000 cells in absence of corticosteroid. If mother has received corticosteroid, this inflammatory response could be truncated, where total leukocyte count can come out to be within normal limits. So the mother has fever, that her total counts is more than 15,000. The baby is showing features of fetal tachycardia, and the fluid that is coming out of cervical cause, that is uh, suggestive of purulent nature, foul smell, or the counts is high in that fluid. All that above and the confirmed triple one is all that plus laboratory findings such as positive amniotic fluid culture, or there are histopathological evidence of infection in the membranes, or, or inflammation in both in placenta on the baby and in placenta. So how do we approach such baby where we have significant risk factor finding in mother? We will see. We will take a look at the child. Uh, if the baby has presented to us within 72 hours of birth, we call it as early onset sepsis. If after 72 hours of live birth is, we call it as late onset sepsis. So EONS or LOS. Then we will take a close look at the features, if there are any perinatal risk factor, or there are neonatal symptoms such as fever, tachycardia. Uh, uh, if there risk factor present and symptoms are absent, then we take step two. We look for the, if there is the risk factor are of extreme variant or not, or if any of the extreme risk factor present, then we start antibiotic then and there and titrate the as per the blood culture report and clinical features in next 48 to 72 hours. If none of the extreme risk factors are present, we will continue to monitor and observe the baby for development of symptoms. Start antibiotic if any change in clinical status, in if any new symptom develop. There is no need for sepsis screen, but send a blood culture before antibiotic initiation. So we can hold on and sepsis screen, but culture should be sent because after starting antibiotics, the culture could turn out to be negative. What are the common features of sepsis in a baby? The baby uh, presenting to you could be lethargic, feeding poorly, mother or nurse reporting that the baby is not looking well, the baby is febrile or could be hypothermic, the baby is having vomiting, diarrhea, distension of abdomen, or presented to you with seizure or dull apathetic look and encephalopathic. Uh, the skin is not looking to be well perfused, or uh, the CFT is prolonged for more than 3 seconds, and the the baby is not passing urine. The blood pressure on recording is showing hypotension. So there are features of poor perfusion and shock, and really the such septic baby presented to you, can be presenting to you with present bleeding, sclerema, that is skin, wooden-like skin, and reduce urine output to the, and rarely with renal failure. So when we assess the child presenting to you with the symptoms of sepsis and risk factor, if the risk factor are suggestive of or clinical symptoms are suggestive of serious sepsis, then we initiate antibiotic and then they send appropriate samples such as blood culture, CBC, CRP, ESR, and we will follow a child according to clinical response as well as investigations. If the child presented to you after 72 hours of life, look at the severity of neonatal symptoms and look for the any risk factor present or not. So if any risk factor is present, start antibiotic and titrate with the child's clinical status and blood culture report. If though no risk factor are present and the neonate is sick, there is strong clinical suspicion, initiate antibiotic and titrate as per blood culture report and clinical report. If the neonate is not too sick, there is single apnea, single feed intolerance, and, and temperature instability is present, send a sepsis screen if turn out to be positive. Initiate antibiotic and titrate with the blood culture report. If a sepsis screen turn out to be negative, keep a close look at to the child. Initiate the antibiotic if there are any worsening of the symptoms. What are the all investigation you have to send total leukocyte count, look for the absolute neutrophil count in the CBC report, send a micro ESR, C reactive protein, immature to total count of that is band cells in a of total neutrophils available in the peripheral blood film. If total leukocyte count is less than 5,000, uh, or if it is more than 15,000, micro ACR is more than 15, CRP is more than 10. If IT ratio, that is band cells, is uh, more than 20% of the total cells on a slide, any of the two above are consistent with a positive sepsis screening. So any of the above two, if they are suggestive, raised, then it suggests a positive screens, and should be antibiotic should be started in that child. If otherwise, then we can hold on antibiotics, look for the clinical features, continue observation. If any deterioration, start antibiotic and resend the sepsis screen. And what antibiotic should be started has to be decided by the specific neonatal unit. It is not possible to recommend a single antibiotic policy for use in all of the newborn unit. It should be based on local culture. So you should send cultures very frequently to the babies coming to your unit, and the environmental culture and should also be sent. Your staff should be frequently screened for contamination infection in the uh, close vicinity of the babies. Keep watch on that data and build up your own neonatal unit um, uh, culture and the sensitivity report that can be used for profiling the type of organism prevailing coming to your prevailing in your society, coming in the children coming to you in your neonatal unit, and that can give you an idea of what antibiotic should you start. If that data is not available, then you can use National Neonatal Perinatal Database. Individual antibiotic and rational combination of antibiotic must be evaluated for the percentage of organism that they cover. The simplest and rational combination of antibiotic must be selected for each line. So, for example, you can make a tablet 3 lines of antibiotic: first line, second line, third line. First line antibiotic should cover 75 to 80% of your NICU or neonatal unit isolates. Whatever the organism you have isolated in last 6 months, uh, so that first line antibiotic should cover around 75% to 80% of all isolate kind described by you in your unit. Second line antibiotic should cover 90 to 95% of isolates, and third line should cover 95 to 100% of isolate in your unit. Initial combination should cover both gram negative and gram positive organisms. It should not be restricted to one side. One should use lowest generation antibiotic combination which would cover around 70% of organism. It is to ensure that you have something to fall back on. Avoid cephalosporin as first line antibiotic, which have been proven harmful. Uh, there are high chances of high risk of extended spectrum beta lactamatosis organism growth in near future in your NICU, increases the candida infection, neonatal enterocolitis, and mortality in your unit, in one specific unit. Have written unit departmental institutional antibiotic policy and practice antibiotic stewardship. Reason for starting the antibiotic, reviewing the plan for antibiotic at 48 hours and again at 5 days based on the culture report and clinical course of that specific child. Have an exit plan to stop antibiotic, to upgrade antibiotic. So you there should be a specific exit plan to that policy. Do not use reserve drug without consultation. So without discussion, you should avoid reserve drugs. Broad spectrum initial antibiotic we have discussed here, ampicillin, fluoxetine with injectable gentamicin. For a child, less than 2 kg, more than 2 kg, so you can look for the doses and keep have a written doses policy as well in your unit. But these antibiotics are suggested, but you can keep other antibiotics as per your unit policy. So you can keep for such planning for sepsis, pneumonia, first line drug, second line drug. So suggested second line drug is piperacillin, tazobactam, amikacin. You know? Similarly, meningitis for confirmed meningitis, cefotaxime, amikacin. For a child less than 2 kg, more than 2 kg, first line drug, second line drug. So you can make such charts in your NICU, in your unit binder, so that you can follow these guidelines. Your staff and your residents could follow these guidelines in a standard manner. As neonate sepsis is dynamic, complex, and heterogeneous condition, intense monitoring, subjective and objective both, have a subjective and objective overview of the clinical situation of the baby. A repeat sepsis screen within 12 hours may be adopted if initial screen is negative and you have a high suspicion of sepsis. Process of taking blood culture, take all aseptic precaution, local disinfection of site with 70% alcohol, then apply povidone iodine, then clean it, then take a sample. Povidone iodine should be avoided in extremely low birth weight babies. Then again apply alcohol. So first 70% alcohol, then iodine, then again alcohol. Then take 1 ml of blood to be put in containing at least 5 ml of broth for culture. Take blood from fresh puncture site, preferably from freshly inserted IV cannula. So these are the guidelines for use of uh, for neonatal sepsis, starting dose of antibiotic, and to monitor and review your newborn. If in case you feel your gut feeling suspicion of infection is very high. Thank you. Thank you, IJCP.
Sorry, sir, I was on mute. Thank you so much, sir, for your wonderful presentation. We do have some question if you like to take that up.
Yeah, yeah.
So, sir, the first question is, what are the key clinical signs of early onset neonatal sepsis versus late neonatal sepsis, and how do they guide management?
So, because early onset sepsis, the common organism which we find in a early onset sepsis have been transmitted from mother during maternal infection or during passage of during delivery passages. So, in our practice, they are gram-negative infection commonly, and on late onset sepsis, they are community organisms or infection acquired from during a hospital stay. So they are slightly different. Chances of meningitis are more common in late onset sepsis. So likewise, we have to devise our antibiotic policy, keeping a difference between the two. But for both late broad spectrum antibiotic has to be initiated, and first line to be initiated at most of the time. But if the child is sick enough, if in shock, or then we should go for second line and line antibiotic from especially in cases of late onset sepsis. There are where the chances of meningitis is high, and the lumbar puncture is a standard of care. It is essential investigation in late onset sepsis, which we can avoid in early onset sepsis. Thank you.
So the another question is there. How
Yeah.
should central line associated bloodstream infection in neonatal be prevented and managed?
So we should have a CLAPSI chart in our each unit, where we keep daily monitoring if catheter is needed, catheter is clean, and it has the toileting around the catheter, skin around catheter is taken care of or not, or if there are frequent handling of catheter without taking appropriate care of the hand on the ports, then it could lead to bloodstream infection through the catheter. So that should be avoided. Our staff should be cautioned enough. They should be trained for use of central catheters. Thereby, we can reduce or uh, mitigate the chances of CLAPSI. And we should keep a tab which on how our CLAPSI rate in our unit.
So there's one last question. What are the critical components of infection control in NICUs to reduce the incidence of neonatal sepsis?
So, because NICU starts from labor room and OT delivery room, so the chances of infection starts from taking appropriate history of from mother, taking care of mother during before and during delivery, keep maintaining hygienic aseptic precaution during neonatal resuscitation, using sterile equipment with appropriate hand hygiene at while cleaning, transferring from baby from an OT to, yeah, labor room to neonatal unit, and then again having a clean aseptic precaution while cannulating, putting a center line, umbilical line, so thereby preventing the, and when taking weights in an ICU, reducing or minimizing an ICU stay of the uh, of staff and the caregivers to the in close proximity with the baby.
Thank you so much, sir. That's all from our audience. Before concluding, sir, any take home message from your end?
So, a newborn baby is very tender, and after taking appropriate care, we can improve the neonatal outcome, improve our NICU mortality and morbidity, reduce the chances of infection and complication, improving the neurological outcome in at-risk septic babies.
Thank you so much, sir, for joining us today. With your permissions, I would like to conclude today's session. Thank you.
Thank you, Sriyan. Thank you.